Thank you, Mr. Chairman. I think it's important that we also realize that many of these cuff repairs are different. And I think it's important for you to try and take home something that you can use. You will see different cuff sizes. You will see cuffs that are amendable to double row fixation. You will see rotator cuff tears that are not amendable to double row. You might see cuff repairs that are in fact very easy. And I think it's important to have a plan for each of these. So just to introduce, I think we must remember we're talking now about massive cuff repairs. We're talking about the patient who you did not expect to see such a bad tear. You did not have an MRI, but here you go. You have this big cuff tear, you have anchors, and now you have to make a plan. So it's important to remember that arthroscopy is still your best option because of the fact of a visualization, as well as the fact that you're not compromising the deltoid. There's a lot of new techniques and research results cannot prove a lot of things yet, but there's definitely options. It's important to balance biological and the mechanical factors. Just to understand that tendon healing occurs at the bony surface, but also tendon itself has poor vascularity. So the blood is originating from the tissue around it, from the bone, as well as the peribursal tissue. So these are factors you must consider when you're thinking about repairing, but also healing the tendon. So how do you eat an elephant? In Africa, we eat it piece by piece. So I'm going to give you some tips on how I approach a massive tear, and we'll discuss each of these. And we'll go through each point, because I think if you have a step-by-step technique, it will be helpful. So it's important that I always try and assess the infraspinatus. You know, you get into arthroscopy and you see no cuff, but as soon as you start debriding and you're able to mobilize the infraspinatus from posterior to anterior, you're able to get more coverage of a humeral head. And that's because of the fixation of the infraspinatus on the tuberosity that's been shown. So next, what do? When I start fixing something, I start with my subscapularis. The problem is often in these massive tears, the subscapularis is also compromised. We have a left shoulder, the humeral head is to the left, your glenoid. This is the comma sign. But often, look, it was lying against the glenoid. And once you start exploring the rotator interval, not cutting the comma sign, you're able to get the free edge of a subscapularis. So in my opinion, the subscapularis is a good starting point. Mobilize the subscapularis, protect the comma sign, and if necessary, mobilize the footprint. Just on another video, you can again see a large subscapularis tear. You can see the comma sign at the top there. You're going to mobilize that and you're going to bring it all the way back. You mobilize, there's nothing on the glenoid. There's your comma sign and there's your free edge of subscap. So I try and start with my subscapularis. Thereafter I move to the supraglenoid area and I want to mobilize my supraspinatus. I'm on the superior surface of a glenoid. I have capsule here. You often have retraction of a capsule, tightness of a capsule. You can see that there's still capsule remaining. You would think this is quite aggressive, but in fact this case it looks quite far medial. But I'm trying to see muscular fibers. If I see muscular fibers, I'm happy that I'm mobilizing and I'm removing the capsule. Then I move on to the glenohumeral ligament. We are busy here in a right shoulder. The glenoid is on this side. The tip of a coracoid is right there. This is the coracoid. And there we are on top of the biceps tendon that is still remaining there. That's your coracoid base there, and this is where your coracohumeral ligament is attached. I also mobilize that. I release this ligament because that can pull your supraspinatus. It keeps your supraspinatus medial, so I release that. You can see there's a pec minor also, aberrant pec minor there. But you want to mobilize the base of a glenoid on the lateral aspect. So we're moving on. We've assessed the extent of the tear. We fixed our subscapularis. we've mobilized mobilized the supraspinatus, and then I like to keep the biceps. And the reason for that is I'm sometimes able to recreate a cable with a biceps. So I'm in the bicipital groove. I'm going to put my anchor in there. I've kept my biceps tendon. I've prepared the footprint already. But I place my anchor again very high, and I'm going to fixate my biceps right there in the groove. But I keep the stump remaining there. Looking at it just on another shoulder or another case, I've already placed my anchor anterior in the groove there. This is a right shoulder. You can see some of infraspinatus is already back on the cuff here, on the tuberosity. And I'm going to place sutures through the biceps, and I'm going to place it through my supraspinatus tendon. So by placing the suture, I'm going to bring part of my biceps onto the infraspinatus, and I'm creating a cable. And I will then fixate my remaining tendon onto that biceps. I just want to see if I can. I wanted to play that video to the full, but we'll come back to that on a later slide. Okay, so I've kept my biceps. I find it to be helpful, and I use it. I like to, in these cases, do an AC excision as well, even if I don't have pain. And the reason for that is often these patients have, this is a left shoulder, your AC joint is right in the depth there, and you will see that you've got a big spur on the AC joint. I mean, that's a big spur, and I prefer to remove that. And that's just to give my rotator cuff and my tendon even a better chance to heal. So we're moving on. We've now removed the spurs. The acromioplasty and AC joint excision allows good blood to get to the tendon. And then, of course, it's always a good option to consider medializing the footprint. And I think it's quite acceptable now to do this also in supraspinatus. You're taking about 5 millimeters of a cartilage away to try and make sure that you don't have too much tension. Again, I've fixated my biceps tendon there, and I'll be using my biceps to augment my repair. And the advantage of a biceps and getting medializing the footprint is I'm able to get a watertight seal. And this is where I want to just show you the end result. So what we have here is a very open, clean tuberosity. I've made some puncture holes in the tuberosity to get bleeding. There's my biceps tendon, infraspinatus, and my supraspinatus attached to my biceps. And then an option, if you are still concerned about the tension on your fixation, I try and do a tension relieving suture. And what we're basically doing is I'm placing an anchor more laterally, and I'm passing sutures, excuse me, medial. You can see that suture is medial to the repair. I'm going to place my suture medial to the repair, and I'm going to use that suture to prevent too much tension on my single row fixation. And it's just another way to try and relieve the tension on the footprint itself to ensure that it heals well. And of course, lateral row fixation with tension sutures going laterally is a very good option and will protect your primary repair. Thank you. And then I'm a big believer in Schneider and his principle of a crimson duvet, and that's where I perform an aggressive removal of bone from a tuberosity, and I prefer to use anchors that allow bleeding from within the bone. I still have time. Just want to mention a few suturing options in these cases. This is a single row fixation. Remember now, this is a different group of patients. This is not the patient where you can do a double row or a small sitting duck supraspinatus. We're talking here about a massive tear. Then a suture configuration such as this is a very good idea. You've got a mattress suture, and with extra protection you have a simple going around that, the arthroscopic Mason Allen. And as you've noticed, I believe also in Laurent's lasso loop that he described in 2006, and this I also use in some of my subscap repairs. You can see there the lasso loop, there's one suture in the anchor, you can see it there, and then the lasso loop going through the 3 tendon of the subscap. And the advantage of this suture configuration is you can get unbelievable pulley effect on that tendon, and you can fixate that tendon onto the footprint very securely without the chance of it ripping out. I think this is a very handy suture, and Bruno, if you could convey my feelings about Laurent's suture, I'll appreciate that. But remember, you still also have alternative options. A partial repair has been shown to be acceptable. So even if you repair subscap and you repair infraspinatus, having a failed supraspinatus or not getting the supra back, you're still doing well. And then obviously we'll have further discussions later on today about the superior capsular repair. Finally, consider these risk factors. Make sure you prepare the bone, soft tissue release, balance, fixation and tension. Try and make it a watertight solution. But not all massive tears need a reverse prosthesis. Thank you very much.